Thank you very much, Dr. Deshmane, Dr. J.K. Sharma. Thank you, Purvi, Manoj, and the whole team of DRS for this honor. And my today's talk is little untraditional. And thank you very much that this topic is one of the rare topic which is being covered in most in meetings. Treatment of hyperglycemia around IVF pregnancy. There's no conflict of interest for this particular session. Thank you, DRS, once again for this keynote address. Now, this is a slide which will have an introduction, some risk and the challenges which we face. Why do we get more GDM in IVF pregnancies? Do we have different strategies, those who are IVF pregnancies versus those who are conventional pregnancies? So, IVF use is rising globally, everyone knows, due to increasing infertility in our society, and IVF is among the most effective ART method. IVF pregnancies carry higher risk of obstetric and perinatal risk than the spontaneous conception, and there is high prevalence of GDM in IVF pregnancies. Uncertainty still remains on the optimal timing of the screening, when there should be screened, specific management strategies in IVF related GDM. There are no clear-cut guidelines and in the management of such pregnancies. Everyone knows that the global incidence of diabetes in reproductive age is growing a concern, and ICMR data itself says that almost out of 94 crore adult people above 18 years of age, almost 24 crores of them, they have glucose intolerance or dysglycemia. And that means every fourth individual above 18 years of age have some kind of dysglycemia. And we know that IGT in non-pregnant state is GDM in pregnancy above 140. And that is why practically every fourth woman otherwise also is likely to have some kind of glucose intolerance during pregnancy. Fertility and pregnancy outcome is again affecting the society, and there is a unique challenge of this assisted reproductive technology when it comes to women developing diabetes. So both maternal as well as neonatal risk increases. IVF itself has been linked to higher propensity of gestational diabetes, adverse perinatal outcome, and complex clinical scenarios in the specialty. GDM guidelines, we don't have the specific recommendation for this, and we have only small reviews, and nationwide evidence and clear national guidelines are still missing globally. And women who conceive with IVF had around 21% higher risk of developing GDM compared to those with spontaneous conception. So global risk, if you say around 17%, India we have around 28, it varies from 18% to almost 22%, and the IDF guidelines said that Southeast Asia every fourth woman, that means almost 25%. So every fourth or fifth woman is likely, and IVF and GDM risk is 43% higher GDM risk in patients who have IVF, and regional spots is 25% prevalence in the Southeast Asia. India, we again have the higher risk of GDM already, and when it comes to IVF, then possibly it's going to be every second woman likely to have some kind of hyperglycemia in pregnancy. Even there could be many cases of mild GDM, which is again a category which is being ignored. Now, what are the risk factors we have? So India, we have the estimated pool of prevalence around 13%, which is possibly much lower mentioned here. Overall, if we say it's around 20%, and we have to have a crucial, and then we also have polycystic ovarian disease. Most of these women who are coming for infertility treatment, they have obesity, they have polycystic ovarian disease, which itself is a concern and a risk factor for diabetes. So what are the factors which is commonly seen in IVF setting is most of these women are at least they are elderly. So if you see the average age of women in GDM, it is 30 years. Common non-GDM, it will be around 28, 29, and in the IVF women, it's around 33.5. And obesity, PCO, and ART procedure itself. What is the pathophysiology about the IVF causing high risk of GDM? So IVF cycle induces the supraphysiological estrogen levels, which can significantly alter the endometrial as well as the placental development. This combined with the metabolic stress inherent with the ART creates a unique physiological environment. Diabetes itself profoundly impacts the reproductive health by affecting oocyte quality and hindering the embryo development and compromising the endometrial receptivity. The synergy between the diabetes and ART further amplifies the risk of critical obstetric complications, which include preeclampsia, macrosomia, preterm birth, along with the potential neonatal metabolic issues that can have long-term implication on the child. So to summarize this particular slide, IVF cycle have supraphysiological estrogen levels and metabolic stress, altered endometrial and placental development. It will have its diabetes effect, compromising the oocyte quality. If you have diabetes, oocyte quality will be, means pre-existing diabetes, then you will have oocyte quality, which might have its impact, embryo development and reduced endometrial receptivity. And the combined risk will be increased risk of preeclampsia, hypertension, macrosomia and preterm birth and other metabolic complications. These children who are born to these mothers have higher risk of having metabolic syndrome in their life. So challenges are high that we have, unfortunately many of them are still 50% of the people with diabetes are still undiagnosed. Those who are diagnosed, they are not taking medication and they are not controlled. Accidental pregnancies are common in our scenario, that's another challenge, but here we are talking about IVF pregnancies. So we have overlapping risk of elderly pregnancy, obesity, PCO, infertility, which all combine together to increases the risk of GDM in such pregnancies. So what are the solutions? What should we do? Practically every woman who is planning for IVF should be undergoing the preconception counseling and care. We should be trying to assess their glycemic status but much before they are planning for IVF. And intensive preconception counseling is must. Screening of all the candidates. It should not be selective. It should be all the candidates, all women before undergoing IVF procedure should be screened for diabetes and pre-diabetes. And if they have pre-diabetes, if they have diabetes, then they should undergo preconception counseling care, achieve all those glycemic targets preconceptionally. These are the preconception counseling norms that we have to achieve: fasting blood glucose less than 92 hours, less than 120, HbA1c to be achieved at ideally less than 6 before getting conceived. If you can achieve up to 6.5 is acceptable, except in type 1 diabetes, where you have to, if in view of hypoglycemia, you can accept up to 7% of HbA1c preconceptional in these ones. But when it comes to IVF pregnancies, and if they have pre-diabetes or diabetes, you should first achieve that. Insulin remains the drug of choice in such women. Insulin is preferred drug, and of course you have to have very strict control and strict monitoring. Oral drugs are not the first line therapy in such pregnancy because they are already high risk individuals, and the doses have to be individualized. These are the targets in type 1, in GDM, and those who are GDM not treated with insulin. Now, there are some guidelines about the management of pregnancy where they have just not too much covered about the IVF pregnancy, but they say that such women should be should be subjected for preconceptual counseling more aggressively, and it should start from the much before you go for the procedure. And these are the checklist from various places. So when you talk about pre-existing already type 1 or type 2 diabetes and undergoing IVF pregnancy, in that situation you have to see for their vasculopathy, rule out microangiopathy. If they have pre-existing retinopathy, you have to assess. There are some absolute contraindications for pregnancy. You should know these contraindications. If someone has proliferative diabetic retinopathy, cardiomyopathy, autonomic gastroparesis, or someone has severe diabetic say coronary artery disease, or even chronic kidney disease, those patients with chronic complications, either any of the vascular complication, there is relative contraindication that we should know about. And if they have everything through, then also see the coexisting drugs. They should not be on statins, they should not be on other oral drugs, they should be only on insulin therapy before they are planning for IVF procedures, and they should be well evaluated for statin should be stopped, ARBs and ACBs if they have hypertension should be stopped beforehand and should be shifted to the safer drug. So good, safe antihypertensive drug, safe glucose lowering therapy, safe, no statins are being allowed except very recent recommendation for the familial hypercholesterolemia, where it has been allowed that if you feel that such patients are having very severe hypercholesterolemia, familial hypercholesterolemia, they may be continued with statin. No other patient should be kept on statins. So these are some of the, and of course smoking cessation, lifestyle modification, weight reduction, all these things should be, and of course retina examination and laser photocoagulation should be done beforehand, and if it is indicated. So these are all preconception things which should be done. Management part, of course, once you are diagnosed to have GDM, those who are, I'm not talking about pre-existing type 1 or type 2 diabetes planning for IVF, but even those who are developing GDM for the first time after the IVF procedure, the treatment remains almost the same line. But here again, instead of metformin or sulfonylurea, we prefer insulin therapy in such women. So basic principle remains the same: medical nutrition therapy, physical activity and weight management. And of course, 70% of them may do well with diet therapy alone, but rest of them may need insulin therapy. But in my opinion, they are elderly patients, high risk women, and many of them have infertility for years together, and sometimes it's just the only chance, and that's why insulin remains the drug of choice for them. Of course, regular exercise will also help. Insulin becomes a drug of choice. All type 1 diabetes, practically all type 2 diabetes and GDM also this becomes a drug of choice. Again, I'm not going in detail of it. Sulfonylurea, though glibenclamide has been approved, but Government of India has, as well as DIPSI, has not approved it yet, and very few people are using it, but not in this IVF pregnancy. Again, I'll avoid metformin at this moment of time unless and until the patient is obese and severe insulin resistance, and where insulin is not so capable enough of achieving good glycemic control, you can add. Insulin remains the drug of choice. And of course, postpartum follow-up of these women is equally important. 85% of these women will become normal after the delivery, but 15% may remain hyperglycemic, and they will again need insulin till they breastfeed the baby. And rest of the women need to be go for postpartum care. So every rule of 6th day, 6 weeks, and then 6 months, and then once in a year you are supposed to go for oral glucose tolerance test or the HbA1c after the 3 months of postpartum. And they should avoid the postpartum weight gain also. That should be our strategy. Ultimately, what is important is we have awareness about GDM now across the country because of the because our Government of India has declared 10th of March is a National GDM Day, and now awareness has become a part of the DIPSI as well as the Government of India. And most of the clinicians who are involved in the care of pregnancy diabetes are involved into education. And we also do this Prega Talk, which is one of this unique program in the world. We have 22 languages in the Constitution of India, and we do this program in all the languages. We have completed first cycle, second cycle, and we have started now the third cycle. And we already completed 6 programs in the third cycle, and we'll continue doing so under the auspicious guidance of Professor Sheshiya. And I'll appeal every one of you, if they're not doing so, please do that. So finally, irrespective whether it's IVF pregnancy or any pregnancy, the glycemic control during the pregnancy is at most important. Early detection, early treatment, early intensive control, and not only neonatal outcome. If you want to give a best outcome in this baby in their adult life, you have to give a good, healthy intrauterine environment to avoid the epigenetic risk of developing non-communicable disease intrauterine. And that is why we say if the glycemic control can be maximized to the extent that the fetus no longer recognizes that the mother has diabetes, then the treatment of mother during the pregnancy may become the first step in the prevention of obesity and diabetes in the offspring of diabetic mother. And this is what is the primordial prevention is before the baby comes in this world. So it is a growing challenge. We need to have holistic approach. It's early screening, intensive glycemic control, collaborative therapy involving gynecologists, involving diabetologists, endocrinologists, and physicians. And the risk has to be explained to the patient. And of course, not only have to have a baby, but also have a healthy baby and healthy future of the baby. And that's why don't underestimate the early control and treatment of GDM to aggressive manner. I always show this slide before I stop, wishing you all a happy Ganesh festival, Onam, Teachers Day, and stay safe, stay healthy, and keep smiling, or stop cutting the cake and cookies, and give another message to the society: cut the fruit, and not the cake to celebrate your birthday or anniversary. Thank you very much for patience. Thank you.